chief instructor for this course. Um, I will be opening the session because he is stuck in another session elsewhere. We have a interesting program now. Planning cataract surgery in a patient with retinal pathology, I think, is very, very important because we come across problems in day-to-day life, in day-to-day practice, about how to do cataract surgery in a patient with retinal pathology. It could be diabetic retinopathy, it could be macular pathology, it could be PC rent management, it could be drop nucleus management, it could be post-operative inflammation, post-operative cystoid macular edema, and what options we have for rehabilitating the patient in terms of secondary IOL implantation options and pigmentation on the IOL by all this by very experienced speakers. But before we start, we have a keynote address. We are very lucky to have today Dr. Malvika Gupta, who is currently a VR surgeon in Melbourne, Australia, and she's traveled long distance to come over to the APAO in Delhi here this year. She's done a UG from Lady Hardinge Medical College, diploma in ophthalmology from the prestigious Maulana Azad Medical College, GNEC, and DNB from Safdarjung Hospital, Delhi, and senior residency from the Ram Manohar Lohia Hospital, also in Delhi. And after that, she has done her VR fellowship in Sydney. And after this very illustrious academic record, she has now set up private practice in Melbourne. And she is founder of her own practice, and it's called Eastern Eye Specialists. I warmly welcome Dr. Malvika Gupta to this course and request her to speak. She'll be speaking on clinical case-based comparative analysis of modern ultra-wide field true color fundus cameras. Please come over, ma'am.
Are we ready to start? Amazing. Good afternoon, everyone. It always is exciting to speak on a forum, but I think here it's extremely special because it's life full circle for me, where I'm coming back to my hometown. Thank you for the kind introduction. And I just thought I will show you, for me, I've moved out of Delhi 10 years ago and I've set up my own practice. But what is really good is that I'm blessed to actually have a beautiful work community and lead a really good full life, but have access to a varied range of equipment, which allows me to be equipped to deal with the talk today, where we talk about multiple modern ultra-wide field cameras. And the main in the industry that we are looking at are the iCare Add-on, the Claris 700, and the Optos. These vary in properties, and I would like to see this from the patient's perspective, but then also bring forward what the doctor sees. So this is the image that you'd often see your orthoptist capture, but this is what the patient sees, quite a clown face. But don't be fooled. What we do see, instead of just seeing a traditional fundus camera, we are seeing the whole wide field. This is how far we've come from the initial evolution from 1851, when ophthalmoscopes were first found. So it's important to have these to be able to pick up asymptomatic pathology in the periphery. This is my own fundus photo on a wide field image, and you can see how the book opens up the moment we offer ultra wide field. Again, this is the image on the Add-on. The previous one was on Claris. And again, the moment we use the ultra wide field module, you can see a whole new world opens up. So there was a lot of ambiguity in the whole nomenclature relating to wide field imaging, and the study group met up in 2019 and labeled wide field as beyond the vortex vein ampullae, which is up to beyond 100 degrees, and ultra wide field, which is further beyond. So up to vortex vein is wide field, and beyond that is ultra wide field. And this is how two modern day cameras today appear, Add-on versus Claris. So again, just a peek into what a wide field versus an ultra wide field image looks. Now, how this came into discussion is when we started doing ETDRS grading for diabetic retinopathy. And here in this image, you can see how how ADON would compare on an ETDRS chart. And you can see that it actually covers most of the fields, just leaving out a little bit superior and inferior. This is just a two-shot image. And there are lots of areas which are left out in other fundus cameras, which the ADON is able to capture just with the two shots. Similarly, comparing it with the Optos, you can see there's all the lashes, which is easily overcome with certain properties of ADON, which I will come to in a minute. So the landmark study that really helps us understand these concepts was this by Federico, which outlined the extent of peripheral imaging, the acquisition time, and the chromaticity, which guides the image quality. What the key findings were that the ADON does provide us a superior image quality with automatic smart mosaic montage feature. It does take a bit longer because it uses 3 shots compared to Claris, which takes 2 shots. But the interoperator variability was much less, considering it was automated. And what was most striking was that it had a superior image quality because it was the only imaging modality which uses true color using white LED light, which reflects the natural spectrum. And then it was truly confocal, where we are able to actually filter out the impact of media opacities, eyelashes, or even the choroidal glow. So in this image, we can see how an Optus wide field compares to a standard Claris photo. You can clearly see that more is visible on an Optus. But what is missing is the resolution and the image quality. So that's where ADON steps in and offers a ultra high image. And for that, we go back to understanding what is the true light, true color with the white light, where it is actually illuminating the retina with the entire visual spectrum and also receiving the entire reflected spectrum, unlike the other modalities. And then it has a wider representation of the red, green, and blue color spectrum, which could be seen on this graph, where we can see that it is more centrally distributed with a wider representation. So being a true color imaging modality, but also being a truly confocal system, where a thin beam of light is reflected to scan the retina, and then the light reflected by a single plane is what is caught on the camera, offers its unique property of being truly confocal and offering a superior image quality. So here we can see the central fundus photo, but the moment sort of you get out in the periphery, often we lose resolution. Here you can maintain the resolution both centrally as well as in the periphery equally. So it's more reliable with a true quality of vision. Brief comparison of what an image would look like on a Claris, Optos, and an ADON, with pseudo colors in Optos, more red saturation in Claris, while a true, more natural looking colors with ADON. Let's not leave Claris behind. It is definitely an exceptional fundus imaging system, again offering good range of image clarity all through, but as we can see on the photos, it looks different, and that's because of the broadline fundus imaging, where it separates the light that illuminates the retina into the red, green, and blue channels, with the retinochoroidal tissue being more red saturated and therefore being a bit more red. It is partly confocal, so it's able to avoid the lashes, and you can still get clear images, but it does have a more sort of red glow from the choroid. So another important feature to consider is the time taken. We know Optos is much shorter at the loss of the resolution of the images. Claris, just a bit longer. ADON does take a bit longer, but it's still almost just a minute and fully automated, and therefore is it too much of an ask to actually achieve a good image quality is what we need to ask ourselves. This is what a smart mosaic looks like. It takes under a minute to achieve this. One benefit of the Zeiss platform is you actually have live visualization, where you can actually see the pupil size and the infrared image to help capture, and that does sort of translate into a more patient-friendly workflow. So let's look at some images which have captured through my ADON, and here we see a small PED, which is so well delineated. This is a very interesting case where I had patients with AMD following up for injections in this eye, but then presented with vision loss in the other eye, and very beautifully captures the area of non-perfusion. But over time, I loved monitoring it every month and saw how you could actually see the same area perfused with the sclerosed vessel in the same area. So excellent visualization. Again, use the same fundus camera to help show my patients why I need to treat them even they have 6/5 vision. My patient here with mild diabetic retinopathy but sursonate retinopathy in an area causing focal leakage and responsible for, and then advocated focal laser for it instead of anti-VEGF treatment, which brought the message home for the patient because otherwise they often wonder why you want to offer treatment. Similarly, another patient who had quite advanced diabetic retinopathy and decided not to get treatment. This is what he ended up with a year later, extensive neovascularization and lost a complete vision with a painful blind eye and neovascular glaucoma. So again, brings back the message home why we need treatments. This photo is really close to my heart. It almost feels like I can go grab that hemorrhage there. It is a pristine quality, and I feel just looking at this, we know that this is an amazing imaging modality. Again, another image showing inferior non-perfused area, head-to-head comparison with another patient I had who also had ischemia. And similarly, just a difference in color is what I want you to have a look and know that this is how it's different. Few images from Claris, I'll be brief minute. So macroaneurysm, CFAN neovascularization, which would have been easily missed. This patient was actually referred as diabetic retinopathy, but later diagnosed to have sickle cell. So largely, this is the summary slide, which is, I think, what tells us that the difference is what you need to see, what you like for your practice, what matters to you most. Is it the image quality? It is the time of acquisition, and how you want to manage your patients with that. Thank you.
Thank you. Thank you very much, Dr. Malvika. You can please be seated. So Malvika has finished her VR fellowship from Sydney, and she's now working in Melbourne, founder of her own practice that is Eastern Eye Specialist. So thank you for that wonderful talk. In the interest of the time, because we are also having a general body meeting in the same hall, and I request our next speaker, an ACE surgeon, the head of the Department of Cornea and Refractive Services at M.M. Joshi Eye Institute. So Dr. K.V. Satyamurthy sir will be speaking on anterior vitrectomy, when, how, and how much. 7 minutes timer, please.
Yeah.
So after that, I request Dur Prasad sir to come on the right side of the podium. Thank you.
Yeah, at the outset, I'd like to thank Dr. Srinivas Joshi for giving me the opportunity to participate in this instruction course. Yeah, right. So now I'll be speaking on when, how, and how much of anterior vitrectomy to be done by an anti-segment surgeon. When we all know, whenever there is vitreous following maybe posticapsular rent or zonal adhesions. So now how and how much, that is more important. So I'll just go through. So don'ts, we know that we should not do open sky vitrectomy because it can lead to traction on the retina, and then vitrectomy can never be complete. So better not to do this, and many people, they don't do it. And now vitreous has a lot of hyaluronic acid, and the whole vitreous swells up if you infuse that. So better not to direct the infusion towards the vitreous cavity. Now here, you can use, vitrectomy, standalone vitrectomy, or that comes with phaco machine, whatever. But what I am interested in is this, a trained, unscrubbed assistant who can saturate your vitrectomy unit in the earliest possible time that it, so that is very important. And it should be a high cutting and moderate vacuum for anterior vitrectomy. This is what I follow. It's better, so that the traction is less in case if you use low cut rate and then high vacuum. The vitrectomy has to be done, these are the principles. One is dry vitrectomy followed by bimanual vitrectomy. Dry vitrectomy is one which is done under viscoelastic substance. As you see here, not playing. Anyway, dry vitrectomy is under viscoelastic substance. Why dry? Because when the vitreous has a tendency to prolapse through the ports. So, in case there are vitreous strands in the side ports or the main entry, then we should wait to this. And then one thing that we should do is not to allow the antechamber to collapse. So keep on injecting viscoelastic as the vitrectomy goes on, and make sure that all the strands which are prolapsing out of the antechamber should be cut, so that we can go on to the next step, bimanual vitrectomy. Here, as I told you in the beginning, if you direct the infusion towards the vitreous cavity, then more and more of vitreous starts coming out, and then you end up doing more vitrectomy. So best thing would be to keep the irrigation parallel to the iris. That is point number one. Second thing, both the vitrectomy probe as well as your infusion should always go through the side port, so that you can convert that into closed chamber technique. And then the vitrector with the port facing up should go beyond the posterior capsule, so that draws all the vitreous that is there in the thing. And always you should advance towards the retina, because to avoid traction when you do this. Video is not playing. ठीक है, नहीं कोई बात नहीं, ये क्लोज करेंगे बाद में. अभी प्ले होता है? हाँ ठीक है. So this is a case of grossly subluxated cataract, where the nucleus was removed, as you saw, through the main through the skeletal incision, and now there are a lot of vitreous that has prolapsed through the main wound, as you see here. So best thing would be to use automated vitrector, and then in this case, because the skeletal was big, so I went through the main incision and under viscoelastic substance. So you see the whole thing was brought to the center, and then under viscoelastic substance, first dry vitrectomy was done, and then whatever vitreous strands were there, again they were swept inside, and they were cut with the automated vitrector. So this is the final thing. Then you do bimanual vitrectomy and then remove the vitreous so that there are no vitreous strands. And since you have done so much of vitrectomy, the globe tends to become little soft. So best thing would be to do a mattress suturing. Both the floor and roof are held together. One can also use triamcinolone acetonide, whatever all the large chunks can be, that shows vitreous, yes. No, yeah, छोटी. Fine. This is how the triamcinolone acetonide, which is available from various companies, we can use, and just put it in the antechamber. Whatever the solid chunks that you are seeing there, that is the vitreous. So the end point would be to remove all these solid chunks, and then this will tell us in case if there are fine strands which are lying on the sclera, on the iris, or prolapsing through the ports. So we'll come to know easily, because vitreous is not that clearly visible. Now, another way is, as I showed you in the previous video, you can just roll the cotton bud around the openings and see the pupil doesn't get distorted. So this is a first dry vitrectomy, remove all the vitreous strands, and then once there are no vitreous strands through the openings, then you can go ahead with the bimanual vitrectomy, where the infusion through one side port and then the cutter through the another side port.
That's somebody else's presentation.
Yeah. Anyway, so to summarize, in case if you're aspirating the loose cortex like this, it's better to do dry aspiration rather than. So to summarize, keep the vitrectomy machine ready all the time. You will never know when we end up with a PC rent or a vitreous in antechamber. Train the OT staff so that you don't lose much time, and use good sharp cutters so that there is no pull on the retina. Stick to the basic principles of dry vitrectomy followed by bimanual vitrectomy, and use good viscoelastic substance to protect corneal endothelium. We have seen many people, they do very good vitrectomy, but at the time they finish the surgery, the cornea will become. So thank you very much for your patient listening.
Thank you, sir. Thank you. Yes, we'll take one question until Dr. Guruprasad sir comes to the floor. Request now next speaker, Dr. S. Guruprasad sir, Senior Vitreoretinal Surgeon from M.M. Joshi Eye Institute, Director of M.M. Joshi Eye Institute. He has a lot of things in his credit. He is one of the high volume vitreous surgeons in India. And he was the first person to start the vitreoretina practice in northern part of Karnataka and Goa. So let's hear from the seniors talk. So before that, one question to Dr. Satyamurthy.
Just one point.
Yeah, please.
All the patients who had vitrectomy, they have a very high incidence. But after PCR, they had a vitrectomy. They had very high incidence of retinal tear and RD. So I think they should be thoroughly screened throughout the life after they had a anterior vitrectomy after PCR. All these patients will have a very high incidence of retinal tear and detachments later. So all these patients must be screened. Most of the cataracts.
No, correct. I mean, your job doesn't end there. You'll have to follow up these cases for two reasons. One is the post-segment problem, as you mentioned. Second thing is the glaucoma, because you have sent in a lot of viscoelastic into the vitreous cavity. And so that is one thing. Yes, thank you very much.
Thank you for the valid point. Yes, we need to follow up these cases at least for a few months and a year so that the development of retinal detachment can be known, and also warn these patients of the early signs of phlegmatogenous retinal detachment like flashes, floaters, or the shadows. 3 important signs has to be named into. Thank you, sir. Thank you for that wonderful talk. I request you to please be seated. Over to Dr. Guruprasad, sir.
Thank you, Dr. Srinivas, both for the opportunity and for the generous introduction. So my topic is the TAS versus endophthalmitis, how to differentiate and how to manage. No financial disclosures relevant to this topic. So TAS basically is a non-infectious, when a non-infectious substance enters the anti-segment, it causes an acute post-operative inflammatory reaction called TAS, toxic anterior segment syndrome. And this can be blinding, can be very dangerous because it causes toxic endothelial cell destruction, and that is a syndrome called TECD syndrome. So post-operative endophthalmitis, on the other hand, is defined as an inflammation of the inner course of the eye resulting from intraocular colonization by infectious agents. This is also potentially blinding. More than half the cases are caused by Staphylococcus epidermidis, and because the inflammation in the eye can be disastrous, and because each can mimic the other initially, at least, a timely diagnosis and management are crucial in both, and the management of each is different, and that is why we have to discuss this topic. So here is the famous list, the list of differentiating factors, but I would like to draw your attention to the 3 marked there with the arrows: the timing of occurrence of the inflammation, the corneal edema, which is different in both, and the vitreous on B scan. So timing of presentation, TAS usually occurs within 24 to 36 hours of surgery. Post-operative endophthalmitis usually around the 5th day of the surgery. Coming to the corneal edema, it is diffuse in TAS with minimal congestion or no congestion sometimes. Limbus to limbus is the typical description given, and patchy in post-operative endophthalmitis, but this congestion here will be severe. And finally, the vitreous on the B scan especially, vitreous is not involved in TAS, but can show membranous vit echoes and choroidal thickening in post-operative endophthalmitis. So we already mentioned about the definition. Non-infectious substance entering the anterior segment and inducing a toxic damage to the intraocular tissues. What are these? Apart from, I'm just going to list out the things that we normally use in cataract surgery. But apart from that, the concentration of intracameral antibiotics that we usually tend to give at the end of surgery also is important. And medications contain preservatives. So I think that can also lead to this postoperative inflammation. Any retained cortex or prolonged surgery, anything that can or has the potential to cause intraocular inflammation, we have to keep in mind. So even full surgery, it could be PC rent, which we just heard about, the retained cortex. And you can see here on this, in the slide on the left, and the arrow pointing towards the linen fiber that can be left behind, which is literally a time bomb. It need not cause immediate intraocular inflammation, but can lead to postoperative inflammation any time during the course of maybe months or years. And this is something that we have to watch. So these are all the drugs, no proprietary interest or financial interest in any of these. These are all the drugs that we commonly use in cataract surgery. Lignocaine, intracamerally, adrenaline, pilocarpine, Viscoat, I'm sorry using the brand name, chondroitin sulfate. Moxifloxacin we use several other things. We use drapes, we use gloves, we use IOLs, and some batches of IOLs can cause problems. This is just an example. So the glove powder, blood on the instruments, which is dried, which is sterile no doubt, but the blood elements can cause inflammation because of their reactionary nature. The blood within the cannulas, which are left behind, not thoroughly washed, and dried and desiccated viscoelastic on the surface of cannulated instruments can also result in postoperative inflammation. So these are all the reasons because of which postoperative inflammation can result in the condition called TAS. Blocked cannulas in the set is something that we should never use. We should just discard it if it is blocked. The nurse is trying to reopen the block by pushing forcibly, which should never be done, because we should understand that the standard flow in a CSSD, when a contaminated device is given to the CSSD department, they clean it, rinse it, dry it, pack it, disinfect it, and then keep it for monitoring and storage. The most important step in all this is the cleaning. So if you cannot clean it, you cannot sterilize it. That is the norm that you should maintain in your mind. So there are some updates on the safety committees, which can help prevent TAS and POE. Basically, it's a platform. The committee is either the VRSI or the IIRSI, the Indian Intraocular Lens Implants Society. Each of which we have to report in case of any inflammation caused by a particular batch of drug or consumable. TAS is amenable for therapy, but not to be taken lightly either. The response to steroids is excellent, but it can cause permanent damage to the endothelium. Prevention should be aimed at, do a root cause analysis, inform the safety committee, follow the safety committee's advisories, make corrections from our own experience and from the colleagues, and train the OT and CSSD staff. Post-operative endophthalmitis, I'll try to finish within a short time. Spectrum of presentation is very wide and depends on the virulence of the organism, size of the inoculum, host resistance, time till consultation, and all these factors in varying degrees can result in endophthalmitis of varying severity. So why should we differentiate? The fulminant type can destroy vision within a day, the ones caused by the gram-negative bacilli, for example. The less acute type can go unnoticed by the patient for a very long time, and if he doesn't examine his eye, doesn't check his vision on his own, he will probably end up in a blind eye. A delayed follow-up visit can be disastrous, and every hour counts, according to me, even if the patient is landing up in a hospital after midnight. There are several instances when we have operated on endophthalmitis patients after midnight as well. So coming briefly to what causes endophthalmitis. Patient factors, CSSD factors, surgical factors, and breach in OT adequate. These are the four I mean, I would like to classify the causes as these four. And patient factors, as you all know, is basically based on the personal hygiene of the patient and also certain nidus of infection, like the molluscum contagiosum or nodules or the sebaceous, not to forget conjunctivitis and ectocystitis. So importance of torchlight examination cannot be overemphasized. It's very important. CSST factors is when we overlook the indicators or overload the instrument or overload the sterilizing equipment when we have a lot of surgeries. Surgical factors, prolonged surgery I already mentioned. Uh, Poorly sutured wound or a gaping wound is something that we have to keep in mind as a potential cause for endophthalmitis. MICS is something, and MDCS is something which I'll just come to. If I think many of us know already what MDCS stands for, it stands for this. This is MDCS. So we should remember that there is some appreciation for fast surgery, but definitely not hurried surgery. It is not a bakery where no, it is nice to see how these bakers work, but at the same time, surgery is something which we should give respect to the eye. So high-speed surgery is something which we should avoid, and there is a certain number of surgeries that we should keep in our mind. We should not be trying to do more surgery just because we have an overload. I think we'll skip this slide. OT etiquette is a subject which is close to my heart, and I think we should, it's a topic which we can discuss for more than 30, 40 minutes. I think we'll not go into the details, but all I want to say is that every step should be properly adhered to. Like the AIOS guidelines are there, change gloves after every case, change the gown after every 3 to 5 cases, and post-operative follow for eventful intraocular surgery, not just eventful, even normal uneventful surgeries also we should follow up in a way that is safe for the surgeon, for the surgeon and the patient too. See the patient on the same evening, again the next day, again on the third day. This is sometimes not practicable, and therefore we have devised a system where we teach the patient about self-assessment of vision every day. We call it the SAVE, which literally saves the patient from endophthalmitis. So lid edema, congestion, pain, and loss of vision are the four symptoms and signs that we explain to the patient that might occur, and loss of vision is something that we have to emphasize on, and this loss of vision has to be reported to the counselor or to the surgeon immediately if such an event happens. The best way to diagnose endophthalmitis early is to practice SAVE. So this is what I was talking about, teaching the patient, the resident is teaching the patient about patient's attendant about finger counting. Just finger counting is enough, no need to read the Snellen's chart in detail. So protocol in a case of increased reaction, to summarize, intensify antibiotic and steroid drops, decompress. Decompression is something that is done like this on the slit lamp itself, under topical anesthesia. The scleral lip of the wound is pressed with a needle, sterile needle, and immediately the cornea becomes clear. We can have some view of what is happening behind, and that I think gives a lot of information about the nature of inflammation. And also provides for microbiological testing and ocular sampling. So I think this is very important. And one thing I would like to share with you is that I never do a biopsy, vitreous biopsy. I've always done a vitrectomy and then sent the material for culture. I would like the opinion of the panelists later. So anterior chamber lavage is something which is underutilized by many anterior segment surgeons. I think this is very easy to do. At the same time, you can get some sample for culture as well.
In the interest of the time, can we just, please?
So intravitreal injection is something that we should all know. So summary is, in one slide I would like to summarize. Timing of inflammation is first day versus fifth day in TAS versus endophthalmitis. Corneal haze is diffuse in TAS, patchy in endophthalmitis. Vitreous affection is important to note. Decompression is a technique which should all follow. Patient really feels better after decompression, and we can also diagnose the posterior segment better. Everyone must know the ABCD of intravitreal injection. I wish I had the time to tell you what ABCD means. Loss of fundus glow is something that warrants urgent referral for vitrectomy. And the save exercise, which I just mentioned, is something that is very, very valuable for prevention of endophthalmitis. Thank you very much.
Thank you, sir. Thank you very much for that beautiful talk on how to differentiate between the endophthalmitis. Request you to please come on the stage. I now request another ACE vitreoretinal surgeon, Dr. Apurva AG. So Dr. Apurva will be speaking on why there will be a cystoid macular edema post-cataract surgery and how do you manage it. Over to Dr. Apurva.
Thank you, sir, for the opportunity. Modern day cataract surgery is quick, safe, precise, and has perfect refractive outcomes, and the patient expects them too. PCME, like we'll be calling pseudophakic cystoid macular edema from now on, is still the most common cause of low vision post-cataract surgery. It ruins our perfect 6-6 N6 outcome. We all know how it can be frustrating. CME has long-term effects, and chronic CME can be potentially untreatable. So, even in an uneventful phacoemulsification, clinical CME can be present in 0.1% to as high as 2.35%, and OCT evidence after phacoemulsification is also a little higher than this. This is clinical CME. Risk factors include age, atherosclerotic disease, younger patients, younger than 55 years of age, ocular conditions like diabetic retinopathy, vein occlusion, uveitis, using PG analogs for antiglaucoma medication, a previous diagnosis of epiretinal membrane, like in this case, who developed CME later, and a history of RD repair. So preoperative risk factor, this is an example, like I was saying, a thin ERM was present preoperatively and this patient ended up developing a PCME. Let's look at this example of a 60-year-old lady. She's a physician and she's had multiple anti-VEGF injections in the right eye for supposed recalcitrant diabetic macular edema, and the left eye is under observation on OCT. So when we do this FFA, the left eye looks okay, but the right eye shows this petaloid leakage in the macula, and she had peripheral capillaritis also, which was undiagnosed clinically for a long time, and this patient ended up receiving Ozurdex after a diagnosis of a probable exacerbation post pseudophakia. So the surgical associated risk factors for PCME include, of course, a complicated cataract surgery. We all know this, that tissue trauma during the surgery, a posterior capsule rupture with vitreous loss, traction, long surgical duration, IOL dislocation, and even an early YAC cap post-operatively are all risk factors for pseudophakic CME. So we know the pathogenesis since our first year of residency, surgical trauma to the intraocular tissues. It could be during the surgery or post-operatively because of the haptic rubbing the iris, wit in the AC, iridocorneal adhesions, causes release of PGs and other inflammatory mediators, and then it increases the permeability of perifoveal capillaries, disrupts the outer blood retinal barrier to be specific, which is why in pseudophakics, there is cystic accumulation of not only intraretinal fluid in the OPL and between the OPL and the INL, but also subretinal fluid. Like you can see in this example showing the difference between a diabetic macular edema with hard exudates and cystic spaces, with the inner blood retina barrier being affected, and a pseudophakic CME where there is a predominant SRF because of the outer blood retina barrier affecting. So I'll just skip this slide and we'll go more clinical. There is, the patient presents with low vision for near and metamorphopsia, but like we all know, the biggest overarching symptom is dissatisfaction, especially it pinches when it's post a premium IOL. So whenever a patient is referred as dull FR by our anterior segment colleagues, it's very important to check for the macular status, no doubt, but a thorough anterior segment examination is crucial. You can see evidence of complicated cataract surgery, maybe in the form of PCR. There'll be, of course, a dull FR and cystic spaces. OCT is the diagnostic modality of choice. FFA can be done rarely in cases where the diagnosis is uncertain. So the treatment includes topical NSAIDs, very popularly used. Oral carbonic anhydrase inhibitors have been known to be effective according to some French studies. Posterior subtenon triamcinolone, intravitreal steroid injections, either IVTA or a DEX implant, and surgery in the form of anterior vitrectomy and pars plana vitrectomy. Topical agents include nepafenac, bromfenac, endomethacin, ketorolac, And interferon is supposed to also work as a novel treatment, which is even economical in fact, because it downregulates not only VEGF but also some other cytokines. Next is periocular steroids in the form of subtenon injection of TA. It is effective for pseudophakic CME. Of course, you have to also relieve the inciting factor here, in this case vitrecin AC iridocorneal adhesions. This particular patient did well with an anterior vitrectomy, release of adhesions and a posterior subtenon TA. So like I showed in the previous slide, it's very important to set the offending factor right. It's not enough to just keep injecting with PST, but also relieve this chronic rubbing of the haptic to the iris tissue. We do an anterior vitrectomy and reposition the haptic into the bag if possible, or at least safely in the sulcus, ensuring there is no rubbing. So then intravitreal steroids, let's look at them. This is an example of the efficacy of a DEX implant, a 63-year-old man who had undergone very uneventful phacoemulsification 3 months prior, and there was absolutely no change with the posterior subtenon. Received his first injection of Ozurdex, however, there was a rebound at 3 months. This is post the second Ozurdex, and then there was a rebound after 3 months of the effect getting over, and then at 1 year after the third Ozurdex, this patient is somehow probably had 3 Ozurdex injections in his destiny. He is holding on very well post 1 year. Some of my last slides, dexamethasone has been shown to have very good effects on recalcitrant macular edema due to Irwin gas, and a laser vitreolysis can be considered in a singular vitreous strand, like in this case. Definitely a YAG vitreolysis is a non-invasive procedure that can be tried. Well, when there is PCME with an ERM or a concomitant VMT, vitrectomy can reduce the concentration of inflammatory mediators and growth factors, and anterior vitrectomy with a pars plana vitrectomy can reduce the load of those factors. Now let's look at this patient. She has been having low vision post-cataract surgery for a very long time, probably more than 6 months. She comes to us and very surprising that she had worsening with PST. Now you can see we gave actually Eylea, which is longer acting, but it kept worsening. What I want to say is this kind of degenerative edema with bridging processes, nothing really works. Anti-VEGFs have been seen to be effective, but there's no significant difference between the anti-VEGF agents. We know that prevention is key. Preoperative NSAIDs may help, especially with Nepafenac, either Nepafenac or Bromfenac or Ketorolac. All of them have pretty similar efficacy. NSAID alone or in combination with steroids is better than steroid alone. Prevention is key. I'll say that again. Preoperatively, check thoroughly for DR, subtle signs of vein occlusion, uveitis, thin epiretinal membranes. Rule out PG analogs if they are being used for glaucoma. Treat these conditions preoperatively. There's definite role of topical NSAIDs perioperatively. Surgical factors, ensuring optimal pupillary dilatation, limiting iris manipulation, clean cataract surgery by limiting surgery-related factors. If there is a cluster of PCME, revisit the type of IOL, any change in the viscoelastics, any new variation employed in surgery, and if there is a PCR, handle it very astutely and with minimal collateral damage. I thank these people for their help. Thank you very much.
Thank you, Dr. Apurva. We'll come to a few of the questions. Request you to please be seated on the stage. I now request another ACE surgeon, Dr. Giriraj Vibhute, the vitreoretinal consultant at Joshi Eye Institute. So he'll be speaking on the secondary IOL options. What do VR people do from VR point of view? So he has done a lot of skill fixated IOLs. I'm sure he'll be able to deliver his best. Over to you, Dr. Giriraj.
Thank you, Srinivas sir, for introduction and for including me in your IC. And modern cataract surgeries are refractive surgeries, but yes, sometimes problems happen and sometimes we do end up with aphakias, and most of the times it is referred to us for further management. What do we do in our regular practice is, it is not always necessary to give a secondary IOL. This lady who was operated 20 years back and who is very happy with aphakic glasses for last 20 years, I would not recommend a secondary IOL for her. So choosing patient is also one of the first things which we do. Aphakic contact lenses can be an option, but according to the study I have included, the most common reason for secondary IOL implantation was to relieve the discomfort caused by spectacle or contact lens use. So in such patients, you can offer the secondary IOL or the spectacle or contact lens independence. So now that we have decided about a secondary IOL, what needs to be done? So if a problem is happening right away, and if you have a vitreoretinal surgeon in the next OT, it can be done in the same sitting, or it can be a deferred procedure. It can be done in a second sitting. Studies have shown that there are no visual, significant changes in the final visual acuity in either of the sittings. So you can do it according to your convenience. So if things are going out of your hand as a cataract surgeon, triple S is the technique which you follow. Triple S means stop, suture, and then send. That is, you can refer. Stop at that time, don't fish, don't try to do anything which is you are not comfortable with, and then you can send the patient. If sulcus is available, obviously it is the ideal choice, but if it is not there, then the conventional 2-point or 4-point fixation comes to our rescue. 2-point fixation, most of us know. Because of time shortage, I have just included a picture. We know under the scleral flap, railroading is done, 90-proline is used, and sutured under the flap. But sutures have, the 90-proline has its own life, and younger patients might require multiple surgeries due to suture erosion or due to suture breakage after some time. So to tackle that, Dr. Satyamurthy sir has taught us this technique with the help of Gore-Tex suture, which is a monofilament porous suture made of PTFE material, that is polytetrafluoroethylene material, which has a life of around 25 years and more. It is commonly used in vascular surgeries. Here we use the AIOS IOL, which has 4 eyelets. The Gore-Tex suture is passed through 4 of these eyelets, and the distance in between the 2 eyelets is 4 millimeters. 2 millimeters away from the limbus and 4 millimeters apart, two openings are made through which this Gore-Tex suture is brought out with the help of intravitreal forceps, which is repeated again on the other side also. And then the 4-point fixated IOL, it sits nicely into the place. You can suture, you can tie a knot under the conjunctiva itself. The material is soft and malleable, so it does not cause pricking sensation to the patient. You can just try to drag the knot towards the scleral side. And yeah, that is how it is done. Then the other techniques are the Chariot's tunnel technique, which is again a commonly used technique where you bring out the haptics of a 3-piece IOL and then you place it inside the tunnels which are made with the help of either 26-gauge needle or cannula, which is the Chariot's tunnel technique. The modification of this is you can fix these with the help of a glue also. That is glued SFIL. Yamane's technique is similar to it, where you use cautery. Because of time, I will not show this video. The 4-flange Canabrava technique is popularized again as dumbbell technique, where you cauterize the edges of a 6-proline suture. We use it, a little modified version of it, in closed globe internal fixation, where this one-sided dislocation of SFIL had happened 7 years after the primary surgery because of trauma. What we did was, after vitrectomy, with the help of chandelier illumination again, we passed a 6-proline suture 2 millimeters away from the limbus inside the vitreous cavity, and then intravitreally we passed it through the SFIL eyelet and brought it out. So it is being passed through the SFIL eyelet intravitreally. Then it is brought out through a corneal opening and flanging is done. So you form a bulb so that it will sit nicely into the haptic, into the eyelet of the SFIOL, and you do the same thing on the other side also. The latest are scleral tuck IOLs, which are gaining popularity in our hands. So it has a T-shaped haptic, it is hydrophilic lens, foldable lens, which is an advantage. Either you can insert it superiorly or temporally. This is the relatively older video. Nowadays, we are using temporal injection, and 23 gauge needle also can be used instead of 23 cannula. You just hold it, bring it out on either side. It sits nicely, and surgery finishes within 15 minutes if it goes well. It has its own problems. Sometimes the tea might break and all, but if it sits nicely, then your work is done in 10 to 15 minutes. I'll just show this. So you hold it. It has its own specialized forceps. So kind of a handshake. You just hold it and bring it back. So this was our own study, which is about to get published, comparative study of sutured decentration and tilt. So we compared it with 2-point fixation scleral technique with the help of Antirion machine and ImageJ software. So the study revealed almost 43 cases in both the groups, and the CMT group had significantly lesser incidence of decentration and tilt both. So yeah, with that, I thank sir, and I hope I'm within time. Thank you.
Fantastic. Thank you, Dr. Giriraj, for showing those beautiful videos. Thank you very much. Please be seated on the dais. Now I request we'll have a quick discussion after 2 more talks, and then we have now Dr. Jay Kelkar, who is an eminent surgeon from Pune, from NIO, National Institute of Ophthalmology. She's a prolific pediatric ophthalmologist as well. So madam will be speaking about the diabetic retinopathy and the cataract. Which one comes first? Whether to treat diabetic macular edema or cataract and then diabetic macular edema, or both with together? Over to you, madam.
Okay. At the outset, I would like to thank Dr. Srinivas Joshi for including me in this topic where all the vitreoretinal surgeons are doling out the expertise. They feel like an outsider, but cataract is a problem which is being tackled by anterior and posterior segment surgeons alike. And though as anterior segment surgeons, we don't have to treat the retina, we should definitely be knowing what exactly is happening in the retina. So there is a growing tendency towards earlier cataract surgery in patients with diabetes, and they want improved visual outcomes. So delaying cataract surgery in patients with significant cataract, where it is not possible to identify or adequately treat the DME before cataract, can lead to poor outcomes. So when cataract surgery is undertaken before lens opacities obscure the macular assessment, the risk of DME is less, and that leads to a better visual outcome. So what are the preoperative considerations? Patients should have a good glycemic control. Avoid surgery in presence of ocular or periocular infection, obviously. Macular edema should be adequately treated before surgery, as pre-existing maculopathy aggravates post-operatively. Patients with pre-existing untreated PDR are more likely to progress and develop vitreous hemorrhage. So best would be to refer these cases to your vitreoretinal colleagues and get a PRP, it's recommended. In patients with pre-existing DME prior to treatment for the same, cataract surgery can increase the risk of progression or a redevelopment of macular edema to 20 to 50%. So perioperative intravitreal steroids, anti-VEGF agents are good options in these cases. So what is the effect of cataract surgery on the retinopathy? So there are several conflicting evidences in literature. Some studies say that diabetic retinopathy progresses after phaco, while some have reported no significant change. Squirrel et al. Have shown an increase in the risk of DR progression following cataract surgery in patients with elevated HbA1c. In a retrospective study, Krepler found out that diabetic retinopathy was associated with male sex, disease duration, and poor glycemic control. So to differentiate between the effect of cataract from natural course of the disease, Dollar et al. Did a huge study, prospective study, showing that uncomplicated phaco cataract surgery does not accelerate the progression. Similarly, Shah and Chen also found that there is no increase in worsening of the diabetic retinopathy. However, the ETDRS study suggested a trend toward increasing retinopathy progression and worsening, and Dennison also reported the same in a huge cohort of patients in the UK. So what is the rationale behind the progression? So uneventful excellent cataract surgery also results in increased inflammatory cytokines in the eye. Patel et al. Reported that day 1 after uneventful phaco and IOL implantation, there were significant increases in the VEGF and the hepatocyte growth factor, the interleukin-1, and the pigment epithelium-derived growth factor concentrations. And these tend to increase up to 1 month and then decline in the postoperative periods. These cytokines induce clinical and subclinical worsening of the diabetic retinopathy and the maculopathy. So what is the effect of cataract surgery on macular edema? So from the results from the key findings of the UK EMR users group, they found there's a sharp increase in treatment requiring DME peaking at 3 to 6 months post-surgery. So the annualized DME rates from 0 to 3 months were 5.2 to 9.1, they went to 4%. So what are the indicators of poor outcomes following cataract surgery? So according to the ETDRS, it's presence of CSME at the time of cataract surgery. So a significantly poor vision is a predictor of final poor vision after surgery. Also, you must always correlate the amount of cataract with the amount of visual loss that the patient has so that you can differentiate how much of it is because of cataract and how much of it is because of the retinopathy. The severity of diabetic retinopathy at the time of surgery plays a huge role. So treatment-naive PDR before cataract surgery may progress to vitreous hemorrhage and TRD following phaco, thus threatens good visual outcome. So visual prognosis, patients will always ask you, okay, how will I fare after? What do I expect? Should I be using premium IOLs? So cataract surgery in diabetes tends to report a lower incidence of complications, and there are better results because better pre-op management, because of evolutions in the operative techniques, better glycemic and hypertensive control, and of course because we are getting better and better at phaco. But diabetic patients with little or no retinopathy, you can give a good visual prognosis similar to those individuals without diabetes. The presence of DME and pre-operatively poor visual acuity are definitely poor markers. And overall, the visual recovery after uncomplicated phaco is governed by macular perfusion status, the presence of macular edema, and the stage of diabetic retinopathy. So to conclude, the number of people with diabetes is increasing exponentially, so it is not the prerogative of only the vitreoretinal surgeon to be treating those. As anterior segment surgeons, we should be aware when we enter the eye, what all complications are we subjecting the patient to. Since we have all read Payman, and he had said that there is a protective effect afforded by the natural crystalline lens in progression of diabetic retinopathy. So as soon as that protective effect is lost because of cataract surgery, definitely there will be progression in the diabetic retinopathy status, and we should all be well aware of that. However, modern surgical and pharmacological therapies allow for safer and effective surgery, and emphasis should be on patient education, and special attention should be given to systemic and ocular conditions. Thank you.
Thank you. Thank you, madam, for that wonderful talk. Request you to please take your seat. We have last two talks left, and we have another ace surgeon who is the head of the Department of Vitreoretina from the prestigious LV Prasad Eye Institute. Request Dr. Mudit Tyagi, because he is also a known figure, national figure in the field of uvea, not just from retina as well. So I request Dr. Mudit Tyagi to also speak on all may not be well in cases of uveitis associated with cataract surgery.
All right, so good afternoon. First of all, let me thank Dr. Srinivas Joshi and the scientific committee for having me here for this talk. Now, I do not do cataract surgeries, but because I do deal with uveitic patients, I do end up referring a lot of these cases to my cataract colleagues, and because of the fact that I also do retinal surgeries, I also end up sometimes taking care of some of the complications that can occur in these cases. So now, what are the indications for doing, first of all, a cataract surgeries in uveitic patients? Now, we must understand that cataract is one of the most common complications of a long-standing chronic or a recurrent uveitis. And it's basically both things. Cataractogenesis occurs because of the inflammation and the uveitis that is there. And cataractogenesis also occurs because of the treatment for uveitis, meaning thereby the steroids that we end up giving to our patients to take care of the cataract. So it's a situation from which there is no escape. You have uveitis, you will develop cataract. You get treated for uveitis, you will develop cataract. It accounts for up to 40% of visual loss in patients with uveitis and is one of the most common indications for surgical intervention in these eyes. Now, overall, if you look at it, uveitic cataracts comprise approximately 1.2% of all cataract surgeries, which may seem minuscule, but if you look at the entire number of surgeries in terms of cataracts being done every year, it's a huge number. And the surgical outcomes are slightly less predictable as compared to a conventional simple cataract surgery that most of our colleagues do. So what are the indications? The first indication for doing a cataract surgery is a lot of times a case where there's an inability to visualize the posterior segment in patients with posterior segment diseases. Now, because the cataract is obscuring your visualization, you do need to get a clear media so as to even understand what's the underlying pathology happening inside the eye. Apart from that, obviously, because of the visual loss that occurs because of a cataract, that's another indication. And sometimes it can be a therapeutic intervention in cases of phacoantigenic uveitis. So what are the challenges that we will face when dealing with uveitic cataracts? There are preoperative factors to be looked for. There is obviously a lack of visualization. small pupils in synechiae, and an unpredictable postoperative course, including an increased incidence of postoperative inflammation in these eyes. So what are the things that as surgeons we should think of in terms of the preoperative management? Remember the 5 A's. Number 1, the age of the patient. Obviously, a pediatric cataract will be slightly different as compared to what you do for an adult uveitic cataract. What is the etiology of the underlying uveitis? And we'll deal to that. Most importantly, activity. Is the eye quiet? The rule of thumb ideal is that you should have a quiescent eye for at least 3 months, but if that's not the case, at least for a month. Associated ocular pathologies need to be taken care of, and associated systemic diseases also need to be under control before we proceed with cataract surgeries in these eyes. Now, like I said, look at the etiology. If it's a Fuchs uveitis, the incidence of cataracts is around 50% in these eyes. These eyes do thankfully have a better prognosis. The other important thing is that usually there are no synechiae in eyes with Fuchs and no cystoid macular edema. The one thing which we need to remember while doing a cataract surgery for these uveitic patients is a very important counseling, because of the fact that Fuchs patients will end up having a lot of floaters. Now, because of cataract, a lot of times these patients do not even appreciate them, but once you get a clear media, your patients are going to question you about the floaters which they are now able to perceive better as compared to what they were doing when they had a visual axis obscured by the cataract. So you need to talk to them, counsel them, and explain to them the incidence or more appreciation of floaters post-operatively, unless and until you intend to also do a vitrectomy along with the cataract surgery, which is a different story altogether. Often your cataract may also be confounded by the presence of an underlying vitritis, and those are cases where you need to slightly tread with caution, because you may have an underlying infective uveitis also occurring concurrently. So rule out infections, and ultrasound B scan becomes extremely important in preoperative assessment of these patients. So this was a patient who had a hypopyon and activity, obviously not a candidate for an cataract surgery at this point of time, but the ultrasound was otherwise fine. On the other hand, we have had patients where there was an active toxoplasma and an active uveitis going on, so you need to take care of them. Non-calamitous anti-uveitis, Behçet's, and VK sympathetic ophthalmia are the other etiologies that you need to keep in mind. Essentially, the point is that you should be aware of the etiology of the case that you are handling at this point of time. Look for signs of inflammation. Like I said, it's important to ensure that the eye is quiescent for at least 3 months. So see if there are any anterior chamber cells there. Get a OCT done if you have got a media which is clear enough. So if there is a cystoid macular edema which is persisting, obvious sign of inflammation, probably you need to take care of the inflammation first before you run into a cataract surgery. Though if you have got a very poor media and you need to get a cataract surgery done to visualize the medium, then obviously this rule doesn't count. But otherwise, ensure that your eyes are quiescent and there is no CME when you get a pre-op OCT done for this. Counseling, like I said, is extremely important in these cases. There is usually a debate between phaco versus SICS versus actually even a lensectomy in a lot of these patients. And there are studies which have shown that the incidence of postoperative inflammation is not different between SICS as well as a nicely done phaco emulsification. A pars plana lensectomy can sometimes be done in eyes where there are extensive synechiae, in eyes with JIA, in eyes where there is hypotonia and ciliary body membranes. Those are eyes which probably may not do well with a conventional cataract surgery, and those are some of the eyes where you may just need to leave the patient AFK. Band-shaped keratopathy and lack of visualization can be other complications which sometimes do need to be taken care of in these eyes. The other problem sometimes can be a very small pupil or presence of synechiae, and then you need to take care of all the other factors which can help you in overcoming these problems, including extensive use of mydriatics, OVDs, pupil stretching, iris hooks, and rings. Intraocular lens implants, there are multiple studies which have compared the role of acrylic versus silicone IOLs, and they have shown that hydrophobic tend to cause less inflammation as compared to silicone IOLs in these eyes. The other complication that you need to be worried about is what happens if there's a PC rent or a PC dehiscence. Please avoid iris fixated IOLs and AC IOLs in eyes which have got a past history of uveitis, because you are essentially irritating iris again and probably laying grounds for more persistent chronic inflammation. In terms of post-operative management, do I have some more time?
30 seconds, sir.
Thank you, that's enough. Yeah. So the other incidences and increased incidence of inflammation that does occur in these eyes, and you need to monitor these patients. You will probably need to treat them aggressively. This was a patient post-uveitic cataract, came with extensive inflammation and a hypopyon, but the cornea otherwise was clear. Started on topical steroids, the inflammatory membrane starts retracting, and within a span of 5 days, you've got a clear media, and the membrane goes away. So you need to monitor these eyes well. You need to take care of the protracted and more exaggerated inflammatory response that is likely to occur in eyes with a past history of uveitis as compared to other cataract. So slow taper of topical steroids, slow taper of oral steroids, and if needed, a continuation of the immunosuppressive therapy that these patients may be in. You also need to be aware of the fact that you will have slightly more incidence of macular edema, so keep that in mind. So in a nutshell, good preoperative assessment, take care of intraoperative issues. If you are prepared and aware of the problems you are going to face, then you will be able to tackle them well, and a more meticulous postoperative management are the keys to having a good outcome in these cases. Thank you so much.
Thank you, sir. So, in the interest of the time, we'll move on quickly. I have 5 more minutes. Can we move on to the next presentation, please? Last presentation. So, premium IOLs with the retinal problem. So, how do we deal with these kind of things? So, that's the important question which needs to be addressed. We all know that multifocal IOLs are often discouraged in patients with or at risk of retinal disorders. So, there's something called as the use of dark adaptation to screen before the multifocal IOL implantation, and identifying patients with early AMD is necessary definitely to avoid suboptimal surgical outcomes. This was something which was reported 2014, that the ADAPT DX dark adaptometer, it works by measuring a patient's rod intercept time, that is the number of minutes it takes for the eye to adapt from bright light to the darkness. So looking at the cost effectiveness of preoperative OCT in cataract evaluation for multifocal IOL, the study says that a preoperative screening OCT during evaluation of patient considering a multifocal IOL added to the cost of the cataract surgery, but the OCT increased the detection of macular pathologies and also improved the QALYs over the time. So let us look at the 3 scenarios. One, 61-year-old software engineer, bilateral drusenoid PED, right eye multifocal IOL. So how to choose and what to choose? There is plethora of IOLs already available in the market for the other eye. So there is definitely the category and the perspective, especially the patients with early maculopathy with pigmentary changes are difficult counseling. However, patients with moderate to severe AMD, there is presence of drusen, geographical atrophy or exudative changes. They are definitely no for multifocal IOL, but definitely yes for monofocal or toric IOLs can benefit from these kind of situations. Now, looking at the pros and the cons, let's look at the cons. Reduced contrast sensitivity, night vision issues, but what are the pros? More freedom, reduced lifetime cost of glasses and contacts, provide better visual experience for the patient. Now, the scenario asked, would you implant a multifocal IOL in a patient with age-related macular degeneration? Few of the authors have described that they are no longer able to drive or engage in activities they love doing. Several articles have listed depression as something not uncommon among the patients with AMD having multifocal IOL. Now, let's look at this slide. Why am I putting this? What is the lifespan of the people in India? Say around 69 or 70 years. Now, look at the demographics of wet AMD. When does it happen? Up to 75 to 80, it is reported as 2.2%, and more than 80, it is 8.2. Let's look at the demographic of geographical atrophy. 75 to 80 is just 1.8. More than 80 is 7%. So the debate always arises here is, why should we not implant a multifocal IOL? So there are several short-term outcomes in combined pars-plana vitrectomy, epiretinal membrane, which have shown that multifocality was achieved, but final visual outcome was delayed because of PCO and macular healing. Let's look at the another scenario, wet AMD or geographical atrophy. Not to worry at all, because we have a plethora of injections already available in the market. Home OCT is now come into the thing, which is the artificial intelligence, that is the Nota Vision, which is also very good, detecting, very nice. Now the last scenario is needing surgical intervention, that is the bleed at the macula. The diffractive multifocal IOL various has been described ghost image, arc shape image, wave shape image, and most of these things. And in these, yes sir.
So the General Body Meeting of 2025 All India Ophthalmological Society is called to order. Because of lack of quorum, we will adjourn and reassemble in 4:30.
Okay, so I'll take just one more minute. Here you can see the surgical scenarios in case of a multifocal IOL. So here, see here, now let us look at this, the case of retinal detachment with the PVR. Now you can see a very bad membranes with a subretinal gliotic. Usually in case of the wide angle viewing, it doesn't cause much of difference at all. Now you can see I'm removing the subretinal gliotic blands even in cases of the multifocal IOLs. I don't see much of problem in these kind of cases. Now let's look into the macular pathologies. So this is again a multifocal IOL. You can see here. Now after doing PVD induction, so when we put the flat lens, now you can see here, sometimes you can see that blurring. Now you see, the blurring is there at the instrument, but what you see at the membrane is very clear. Sometimes the membrane is clear. So these kind of things will definitely has to be there, but definitely with the use of the filters, now you can see I'm using it with the monochrome, definitely you can peel this without much of problem, but definitely it will be a little bit of problem. So some people have, authors have said that you can coat it with a viscoat on the anterior and the posterior surface of these multifocal IOL so that you don't get these ghost kind of images. So lastly, I would like to say, whether multifocal intraocular lenses and retinal disease, there's a very beautiful paper by Andrew Gribowski. We were unable to find evidence suggesting that patients with macular disease should be advised against multifocal IOL. Several contraindications for MIOLs in the patients with diseases have a hypothetical character and are not evidence-based. So more research is needed, especially to address the effect of multifocal IOLs. So by this, I would like to end this talk. Thank you very much, and thank you, expert panel. I thank all the speakers who have been kind enough, and due to a little paucity of time because we are having a general body meeting here, I also thank the keynote speaker and rest of the speakers for their wonderful deliberations. Thank you, delegates. Thank you.
एक नंबर आना चाहिए यार उसको वहाँ पर इसमें करवा के पावर हाँ ठीक है सर आ गया ऑडियो चेक करना एचडीएमआई निकाल हाँ लगा दिया भाई नहीं हाँ ठीक है डुप्लीकेट आ गया ना ऑडियो बात चेक करना नहीं यार आ गया